And to dive into this important conversation, we have an outstanding lineup of panelists joining us. Please give a warm round of applause for Dana de Herrera Smith, Director of Community Engagement and Development at Porchlight Health, Dr. Jasmine Burns, founder, owner, CEO, and psychologist at Burns Virtual Psychology Solutions, Dr. Joanne Schaefer, President and CEO of CIRV Healthcare Consulting and Coaching, Dr. Mary Oz, founder of Radical Change Coaching, Lonnie Fagel, licensed professional clinical counselor, an approved consultant, speaker, author, and educator at Lonnie Fagel Training and Consultation, LLC. Dr. Matthew Gallaty, founder and president of Changes Initiative, and Asaya Chidi, LMFT, licensed marriage and family therapist, founder and CEO of Ethereal Connectiveness Incorporated, founder and executive director of Realign Her. Let's give them a huge round of applause. All right, take it away.
Hello, can you guys hear me? All righty. Well, thank you so much for that introduction. I'm Dr. Jasmine Burns. We're actually going to add to our intros a little bit just to provide some more background information into why this topic is so important to us. So I'm going to start. I know we're a little out of order, but Matt, can you go ahead and start?
Hi, I'm Dr. Matthew Galati. I'm a medical provider. I'm a family doctor, but I'm also integrative medicine trained. Um, I'm also a brain injury survivor, and I'm the founder of a nonprofit called Brain Changes Initiative. So in 2013, as a second year medical student, I was in a very serious car accident. Um, Basically, was driving back to my medical school. Weather conditions were really bad. There was a detour route off the highway. Got onto the detour route, car spun out of control, collided with a tree, had a number of injuries, skull fractures, rib fractures, collapsed both my lungs. I severed a nerve in my face, so for months it looked like I suffered a stroke. And most critically, I had a severe traumatic brain injury. So I had a bleed inside my brain, subarachnoid hemorrhage, and woke up from a 3-day coma, couldn't walk, couldn't talk, had to relearn everything from scratch. And this was at a time in medicine that very little was known about the brain or healing the brain, neuroplasticity. So, as you can imagine, my prognosis was very poor, and the medical providers were guarded in any expectations they were giving my family about my potential return to my medical studies. So, I decided to look up research on my own, and through all of my research and studies, came across 6 lifestyle pillars which are essential for healing the brain, and not just the brain but the body, because as we've heard from all the other panelists on previous discussions, the brain and body are intimately connected. So the 6 pillars that I used were aerobic exercise, cognitive stimulation, brain healthy diets or nutrition, mindfulness meditation, sleep hygiene, and limiting harmful exposures. Very simple. Um, Made a full recovery, returned to my medical studies. My marks actually improved, and I was kind of ashamed and embarrassed in my studies of my brain injury because there was such a stigma about it at the time. But um, I as time and insight set in, I really started to think to myself like I could really help a lot of people. So I started Brain Changes Initiative, which is a nonprofit dedicated to helping other people heal and recover from traumatic brain injury.
I'm Lonnie Fagel. I am a licensed professional clinical counselor. I'm based in Minneapolis. I specialize in medical trauma, ambiguous loss, and health anxiety, amongst other trauma. I have a very similar parallel story as Matthew. I grew up with significant health issues that nobody knew what they were. They were just weird immune responses. And I also have a genetic cancer mutation. So my whole life has lived in this kind of parallel of going to physicians, waiting on science and things to tell me what's next. Um, but my story is about 9 years ago, I was actually finishing my master's in clinical psychology. I was applying to health psychology doctoral programs, and I got very sick. And I was in acute kidney failure, hyperthyroid. My whole system basically had shut down. And I was living in Los Angeles at the time. They had no idea. And my doctors passed me from one doctor to another, and I started to lose my cognitive functioning. I had difficulty walking. I had tremors, on and on and on. Um, and at the time, the basis of my work was in mental health for women with breast cancer or high risk. And so I was already on that path to studying health psychology and the impact of mental and physical health. But after this experience, I guess the story I could say is my kind of turning point is I went to the emergency room. I was very sick. As a therapist, if somebody came into my room, I'm like, oh, they have symptoms of depression. But I was failing. My hair was falling out, my cognitive. I was trying to be in school. And they said, well, we'd like to admit you have depression. And I said, nope. And walked out, AMA. And luckily, I'd been working with a cancer nonprofit at the time. They looked at my labs and were like, no, something's wrong. And they sent me to Mayo Clinic in Rochester, Minnesota, and was there for 3 hours. And it took that one physician, 36 years, one physician to say, oh, this is what's happening. You have a half hour, go pack a bag, you're going to the hospital. We didn't know I was coming out. We didn't know what was going to happen. They said I could have 3 days, I could have 3 months, I could have 3 years. And to which I said, okay, challenge accepted. But I had to accept that this was my reality and there was no going back to who I was before. And so in my work as a therapist, I specialize in medical trauma because I hear people who have gone through similar stories like I have, where they felt dismissed by the medical system, where they had true physical conditions that were treated as, oh, it's just depression. And so that is my passion, and my passion is really trying to integrate mental and physical health and have more collaborative care for better outcomes of patients.
I'm Dr. Joanne Schaefer. I'm also a family physician. I was trained in whole person biopsychosocial models 35 years ago. It feels weird to say that. I am also an integral coach, certified integral coach. So I do coaching of physicians and executives mainly in my practice. I'm also an 18-year-old grateful liver transplant recipient and have struggled a lot with chronic health disease, but I'm very healthy since my transplant. And I did have a chronic encephalopathy, which is a very chemically related to a bad liver brain slowing prior to my transplant. That was immediately gone the second I woke up from my transplant, and I knew my brain was better. So that was a wild ride prior to my transplant, but it was an interesting feeling to know what your brain feels like when your liver can't process versus when it gets a brand new liver and it is clearing out toxins. It was a life-altering moment. The whole experience, I had a birth defect in my liver that I did not know that I knew I had until the last day of my residency, but I made it 14 years before transplant. So I just bring that up because it was a real astonishing moment for me to realize just how profound your brain is impacted when it can't clear your just metabolic rate waste. So that's me.
Hello, I am Dana D. Herrera-Smith. I'm the non-clinical, non-medical leg of this panel, so that's lovely. But am a public health professional, so I get the opportunity to look at things from a system level and at a systemic level, population level, where I know sometimes our clinical folks are trained to look at the individual, right? And so I think that that's important to think about as we're having these conversations, is how do we improve our systems and change our systems? So I work in the substance use disorder space. I work for a company called Porchlight Health, which provides outpatient substance use disorder treatment in Colorado and New Mexico. And much like these folks, there's a reason you go into this work, right? You don't just wake up and decide to work with really challenging populations who experience a lot of trauma and challenges. You do it because you are passionate about it. And so I grew up in a very rural, low-income community, and loved and lost a lot of people to substance use disorder. And realized that we had to make some changes because the war on drugs wasn't working, right? We can't arrest people out of our problem. We can't just continue to put them in jail for showing symptoms of a disease. And so really wanting to work in systems that will support people in getting the help that they need for a medical challenge and a medical symptom. So I get the opportunity to work in a harm reduction space, so really keeping people safe. I tell people often that the #1 qualifier to engage in substance use disorder treatment is that you have to be alive. If you're dead, you don't get treatment, you don't get recovery. And so being sure that we are giving people opportunities to keep themselves safe so they can actually pursue treatment and recovery when and if that is right for them, and then making it as easy as possible for them to do that. So I'm very fortunate to work in a space where that is the priority, and prioritizing access to care and minimizing barriers for people who are seeking those supports.
Hello, my name is Acacia Chadai. I am a licensed marriage and family therapist. I have my private practice where I work with individuals who are experiencing the same things that I experienced in my life. I grew up in foster care in Oakland, California. There were certain perils and socioeconomic status effects that I had to navigate. And what I learned early on, being in therapy as a child, was that it was something special about it. I may not have had the words at that level, but what I think I was benefiting from was co-regulation. And so I was able to take that with me. I knew that that was something special. Later in life, I found myself in a hospital with certain symptoms, and they ran all kind of tests. I think I slept and rested most of the time. I may have been 30 years old at that time. And I remember a physician sharing with me after she sat next to me on the bed, and she shared that, you know, Acacia, we're going to send you home tomorrow. And I said, well, send me home? What's wrong with me? I don't know what's going on. And she said, well, we just don't have a cure for a broken heart. And that's when I knew I needed to re-enter into therapy again, because I didn't at that time in my life have the same barriers that I had had before, finances, et cetera. I was in a place in my life where I probably should have been more overjoyed. So since then, I was able to find a connection with a therapist at some point, but it took for me to work with or attempt to work with several therapists. And what I learned is that I was overwhelming my therapist with things that I had experienced just from coming from the environment that I was born and raised in. So at that point, I decided to go into psychology to, #1, learn myself, but also to be able to work with individuals within my community. Thank you.
Hi, I'm Dr. Mary Oz, and for those of you who are Wicked fans, here in the land of Oz, we believe in 3 things: inclusivity, magic, and very deep healing. I'm also the founder of Radical Change Coaching, which is a coaching company. We have 16 coaches back in Long Island, New York, and we have coaches that are trained to help people grow, heal, and transform their lives. And I think the quickest thing I can share with you is what makes us so different, right? How do we deliver breakthroughs so quickly, as early as session 1? And it really is about our coaching system, which is really our helping modality, which I would love to see enter the lives of more therapists and energy healers. So the 2 or 3 biggest things are, I don't believe as a therapist, when I sit across from someone, I have any business trying to help them, unless I'm going to help them understand themselves better and help them radically change their own life because of who they are, based on what they need and based on who they are. So that's my first thing. And then the second thing is, can I ask you 2 questions today? The first one is, how's your relationship to yourself? Just have you think about that for a minute. And the other one seems a little trickier, but it's just as powerful. How are you relating to relating? And this is what I find as a therapist for over 40 years. Now, I may not look that old. I actually look young, but I have been in the field for 40 years. And I think the difference is when we help people, we help them understand their emotional makeup. What makes them tick? When they wake up in the morning, in order to be happier and healthier, what do they need? Do they need more love? Do they need more certainty? Do they need more significance? Or do they need more variety in their life? So I'm here today to happily share that there are so many different ways to help people in the helping fields. But I would love to see us focus more on cutting-edge ways. That's not so much about people's past or their presenting problem and pain, but we need to go way beyond that, radically change their life so they understand who they are, what they need, and how to naturally improve their relationships.
Thank you. And I'll keep my intro brief here. But so I'm a licensed clinical psychologist, and I specialize in working with autistic individuals. I do diagnostic evaluations across the lifespan. And what I've been noticing is I'm getting a lot of women in their 30s, 40s, 50s. And by the time they get to me, they have just a slew of diagnoses that is like borderline personality disorder, depression, things like they're difficult to work with, and all of these. And a lot of these women are moms who are overwhelmed because they're holding down the household. They have loud children. Sensory overwhelm is a real thing, even as an adult. And so when I'm working with them, I'm asking about their medical history, because a lot of these women are also going through like perimenopause, and that brings its own stuff. And by looking at the patient as a whole versus just the symptom, I'm able to, still accurately diagnose them if, of course, they're meeting criteria and whatnot, but I'm able to understand their journey into how they have kind of been ignored by healthcare professionals. They don't trust the system. And when they finally connect with me, they're like, thank you for seeing me. Thank you for helping me. And so I think, and this is what we're going to branch into, we need to be working with our clients, our patients as a whole person, and not just looking at charts and things like that. So Matt, I'm actually going to kick this over to you. So again, one of the biggest gaps, as I mentioned, is that mental health is not part of routine medical care. We're, again, treating labs and scans and not the whole person. So you connect brain and heart health in your work. What does that overlap tell us about how we should be treating mental health?
Thank you. Yeah, you touched on something that I think is a common theme throughout this whole conference, all 3 days. It's that, we have to treat the body and brain as a whole, right? The brain and the body are very intimately connected. The cerebrovascular system is actually part of the larger cardiovascular system. It's how our blood, our heart pumps blood, oxygen, nutrients to our brain. Also the nervous system directly impacts the cardiovascular system. I heard somebody on the last panel talk about the parasympathetic and sympathetic nervous system. So through hormones and nerves, our brain directly communicates with our heart. Despite this overlap, there seems to be a difference in the way mental health and cardiovascular health are treated. It seems like in Western medicine, at least, that mental health is treated very reactively versus proactively. So like if I take it back to the research, like some of the most validated research we have in preventative care is actually rooted in the cardiovascular system. So the Mediterranean and DASH diet that we as physicians counsel patients about all the time. Also, there's a common theme in medicine to counsel patients about, for cardiovascular health, you need 20 minutes of moderate intensity or cardiovascular exercise 2 to 3 times a week, 3 to 5 times a week. And the strange thing is that actually what's heart healthy actually is brain healthy. And there's a lot of emerging evidence around cardiovascular exercise being the best form of exercise for the brain. It releases brain-derived neurotrophic factor, which is actually a protein that promotes the growth of new brain cells. It upregulates all of our neurohormones like dopamine, serotonin, norepinephrine. Serotonin is your happy hormone. And yeah, despite that, it seems like that mental health is still being treated very reactively. So I think there's in functional medicine there is this concept of, or actually I like to use the analogy of a garden. So we can't grow beautiful flowers in a frozen tundra. You need all the environmental conditions. You need sunlight. You need moisture. You need fertile soil. Well, the brain is the same. So if we give it the best environment for it to heal and thrive proactively, it's going to heal and thrive. So that's exercise, that's focusing on relationships, that's diet, that's sleep, all of the holistic things that everybody's been talking about.
Lonnie, from your lived experience, what was it like for you navigating a system where the mental and physical health weren't being treated together?
It's very isolating and it's overwhelming. So when you have complex medical conditions or you're just trying to seek answers, you are going from one doctor to another and sent from one room to another, having to repeat your story over and over again. When we have intakes, we don't see prior charts. We say, okay, tell me your story. That's also happening with patients who are going for, endometriosis symptoms or cancer symptoms. And so by having people acknowledge, like, this is very overwhelming, let me talk to it. Let me read your chart before you sit down, so I'm not going to have to re-traumatize you. Or your chart is like this big. Whoa, you've been through a lot. I once had a nurse say, wow, you've been busy. And I said, yes, I have. Thank you very much. But by reading my chart, I don't need to repeat everything that I've gone through my whole life, or every single doctor, every single test. You have those scans. Same with mental health. We're asking people to tell them the same thing. So if we have a universal way of connecting, of consulting, I try and consult or refer with primary care physicians or naturopathic physicians. How do we have more integrative care? So basically, it's not having to retell your story every single time, and also know that I'm talking about my physical health. My doctor's also going to ask me about my mental health. I think the best example is this past year I went through surgery for some breast cancer stuff, and I've never had a physician say, how are you doing? So with my treatment plan of surgery, it was, okay, now go. But how do I deal with it? It's an amputation. It's like a whole life change. It's time you've lost. I had a wonderful doctor who said, how are you doing? What do you need? This was my experience with breast cancer. Your surgery is going to be different than mine, but I felt seen. And I think at the end of the day, we just want to feel seen and validated. She said, have you talked to a therapist? And of course, my big thing is therapists need therapy. And so yes, I have somebody to help me process through my medical trauma and the grief and loss of myself. And so having those physicians be able to ask those questions and say, hey, I know this great therapist who might be able to help you. Let me talk to her. Let's find an ROI. That's what's helpful. And that's how we navigate the system. There's a quote that I really like from Plato, and it's the greatest mistake physicians can make is attempting to cure the mind without attempting to cure the body. And there is research that shows that when we integrate mental health and physical health, there are better client outcomes. I don't get people who are coming into my office having 5 years of trying to get an answer and feeling dismissed. And, oh, well, is it just your anxiety? Or have you taken a walk today? Or have you done yoga? Versus, I'm so fatigued, I cannot get out of bed, but I want to do things. That's not depression to me. That says, have you asked about your thyroid? Or had your B12 checked? So it's that integrative care and connecting and collaborating.
Thank you. That's wonderful. And so, Acacia, I'm going to pass this question to you real quick. From a more trauma-informed perspective, what's missing when care isn't holistic?
Yeah, so from a trauma-informed perspective, I think what's missing is we need to fully understand the individual that's in front of us, not just their symptoms. In addition to that, trauma impacts the brain and the body's response to stress. So educating the individuals that we're working with, not helping, in my field, we're helping them maybe understand and learn what they're feeling, probably for the first time. But maybe what's missing is also helping them to understand why their nervous system may be responding to the situation the way that it is. I would go an extra mile and say, I think it was Lonnie that spoke about integrating. So I understand due to the bureaucracy, I think I was speaking about this earlier, that physicians may have a limited amount of time that they are with the client, but some of the symptoms that's coming to the surface could probably be attributed to the same root cause. So their physicians are seeing the same things that we're seeing as clinicians. So perhaps if we clinicians, practitioners, and doctors could maybe work with each other a little more, perhaps the answers that are not available to the physician because of the time restraint, I might be able, to articulate it and advocate on behalf of the client so that we can provide an integrative care that's best for the people that we're working with and working for.
Thank you. So it's not necessarily just like a knowledge gap. This is a system design issue. So, in heart disease, we don't wait for the heart attack. We're, again, taking these proactive steps. But in mental health and substance use, we're often waiting until things are quite severe before seeking help. So by the time that many people reach evaluation and treatment, they've been struggling for years. So Dana, this question is for you. In substance use, intervention is often coming late. So what would early intervention look like in that space?
Yeah, so I think a lot of times when we talk about prevention, we talk about youth and not acknowledging that a lot of times folks fall into substance use or find themselves with a substance use disorder when they are in their 20s, their 30s, and it's often followed by, maybe a really challenging time in their life. It's people use drugs to cope, right? I think we would all be lying if we said that drugs didn't work. They make people feel better, and so people use them to feel better. And then things don't go so well sometimes. And so I think making sure that we're supporting people when they do experience challenging events in their life, when you are seeing people in your world struggling to cope. I think this is really important for our medical professionals as well as our mental health professionals. When things start getting kind of not so great, asking people how they're coping and what support do they need. I think education is really important. Most of the time when our patients come to us, they've been through the system a very, very long time, whether that's the medical system or the legal system. And so making sure that the people in those spaces know when to identify risk of substance use disorder or when it's happening. I've worked with GIs or gastrointestinal folks who have seen really bad liver outcomes, and they go, oh, you should really probably stop drinking. Okay, what do I do about that? You didn't provide any sort of resources, you didn't provide any lists. Oftentimes people will recommend rehab or inpatient therapy and not acknowledging the access barriers that people face. Not everybody can leave home for 30 days, 60 days, 90 days. People have jobs, people have people to take care of. And so what does outpatient look like? What does virtual support look like? How do we just get you started? Because we don't expect perfection in anything else that we do in the medical space, right? If somebody has heart disease or diabetes and we say, hey, you need some lifestyle changes, and then they're really, really struggling with that, we don't say, okay, you don't no longer get to be a patient with us. We're done working with you because you're not doing the things that we told you to do. But we do that in substance use. And so giving people the tools to kind of change their behavior, again, using a harm reduction and a low barrier kind of perspective to say, okay, what things can you do? Can you drink one drink less a week? Can you maybe stop injecting your substances and start smoking them so that we're protecting your veins and your cardiovascular system? And so just really providing education to anybody who's touching somebody with a substance use disorder, which is almost everybody, in terms of how do we support them with moderation, how do we support them in getting the access that's going to fit with their life and that's going to be sustainable, because substance use disorder is not a one-time thing. You live with it for the rest of your life, and you need to have tools that are aligned with what you can do in your life in order to be successful there, and give people the support when they fail, because failing does happen all the time in substance use disorder. And so rather than saying you failed, you say, hey, I'm glad you're back here again. Let's do this again. What didn't work? And how do we continue to support you so that maybe next time this thing happens in your life, you have a better way to address it.
I love that. Very supportive and not condescending or shaming, right? So I love that. And panelists, I'm just going to let you know I'm going to be skipping certain questions because of time. So I'm going to give this question to Joanne and Mary because we haven't heard from them as much. So Joanne, I'm going to start with you. Why do we tend to default to crisis instead of prevention?
Well, I think, first of all, our system was designed to default to crisis because we never covered financially prevention. We didn't even talk about it. So our health insurance was set up that way. Even on the medical side, we didn't cover prevention until recently when it was mandated under the ACA. So that was a big shift. It took forever to get prevention. I mean, even when was it, in the 70s when the pap smear was invented and cervical cancer rates went down tremendously, then people started really recognizing the power of cervical cancer prevention. But as medical advanced in giving more prevention, I think that it's just starting in mental health. I mean, they're starting finally to mandate mental health screening in the elderly, and they pay for it. So what a concept in Medicare. You can actually, as a physician, bill for screening and get paid. But we have a long way to go. And I know we'll get to the question about what's changed, so I'll stop there.
So Mary,
Same question?
Yes.
Yeah. So I think from the perspective of a therapist, it starts with self-awareness. How do we help people be more self-aware, have more self-understanding about their emotional world? What makes them happy? What makes them healthy? To help people understand, how do you make a commitment to yourself that if you want to be happier and you want to be healthier, you have to know your insides. You have to heal from within. So I think it's self-awareness, I think it's education, I think it's self-understanding. I think there's a concept called innate healthiness. I think we need to educate people more about what is innate healthy and what's not innate healthy. And when we enter relationships that are not healthy, I think that drives people to crisis pretty quickly. So I think we also need some education around what's a healthy relationship, not only to yourself, to your life, but also to the people that you love the most. And what the heck do you do when you end up with some unhealthy people in your life every day? I think if we could educate around those things, we would see less crisis.
Thank you. So I want to name this directly. Why don't we currently treat mental health like heart disease? I personally think that part of the reason is mental health is complex, it's subjective, it's hard to see. It doesn't fit neatly into these standardized systems, and our system is not built for that. So Dana, what barriers do you see in substance use at this time, like insurance, access, stigma?
Stigma, for sure, right? People are very uncomfortable talking about substance use, and I bet you if I told everybody to raise their hand, I'm not going to do that because I'm not that rude. You would all say that you know somebody or love somebody or are connected to somebody who has struggled with substance use disorder, and you probably haven't talked about it. Maybe you have. I hope you have, because I think stigma really prevents people from seeking care. I think that they, when they do seek care, if you have a judgmental response from the person that you shared that with, you're going to go right back to what you were doing because now you feel not good about it. You feel like you reached out for help and you didn't get that support. I also want to name access. I think that there is a ton of systemic barriers to people engaging in care and receiving the services that they need. That's everything from finances, insurance coverage, Transportation, I know we've talked a lot about food in this space. Not everybody has access to a grocery store. Some people are shopping at gas stations for their food. And so how do we provide them with additional supports? How do we wrap around with supportive care, right? When we talk about heart disease, you don't just go to the cardiologist, you also go to the nutritionist, the dietitian, the primary care provider. We hook you up with all these other people to make sure that you have the resources you need to take the best care of yourself. And I think that's really important for us to do in substance use as well, making sure that you can get to your appointments, making sure that you do have access to the medication that you need to pick up. You do have access to counseling or free 12-step groups, whatever that looks like for you. So yeah, I mean, there's a lot of barriers still, but it is getting better, and I think we have to work together to support the people.
Absolutely. And so Lonnie, for you, what barriers were you experiencing in your care?
I think the barriers I talked about was physicians, therapists, PT, they work in silos. They're not working together, so they're not talking together. I've lived kind of all over. I've been at major medical, systems like Northwestern and UCLA and St. John's and Cedars-Sinai. I didn't experience integrated care until I went to Mayo, and this is not an all or nothing. I was very fortunate. But the barriers are, right, that was the question. Right, the barriers are, it's the lack of communication. I'm treating this, you're treating that. We're not treating the whole person. We're not treating the whole system. If somebody comes to me like, I'm having really bad side effects from my medication, I say, okay, well, have you talked to your doctor? Well, is this just more anxiety? Okay, well, have you talked to your doctor? Well, I don't know. And so it's asking questions. And I think the barriers are people are afraid to ask and advocate because doctors know everything. They're supposed to be the be-all, end-all. Or I heard this on TikTok, and TikTok told me that my diagnosis is this, and my doctor doesn't know. So that's a barrier. And so it is. And it's something that's frustrating for me. It's like, ask the team. So I think the barrier is when we're not working together. We're not integrating care. I think for me, the most significant thing is also the emotional access to care. Because when you're constantly going to the physician, to a doctor and saying, no, that's not it, and then you're sent somewhere else, or people are called like they're seeking medical care because they're just trying to be heard, and they go from one doctor to another who doesn't ask questions, who's like, well, I don't know. But they're like, no, there's something wrong with me, I know, and people are not being trusted. So trusting the patient, and then as well as patients advocating for themselves, and then the integrative care and communication.
Love that. And again, roll with me, panelists. So Joanne, I'm going to ask you real quick. You've been in the field, as you said, for 30 plus years in various roles. What changes have you seen in the way mental health is being treated?
I know we still have a long way to go, but just reflecting back on my career when I started, 30 plus years ago, when people in mental health crisis came into the hospital, they were stuck in the ER. I realize this still happens today, but 30 plus years ago, you were stuck in the ER. You could be there for 70 hours plus, never get a bed in the hospital, be handcuffed to the bed for hours. Maybe security would see you. You would be chemically and physically restrained for hours on end until an institution would take you. Now there are laws against that. In hospitals are fined. In one of my jobs, I was the person handing out those fines. You cannot do that to mental health patients anymore. They have limited time that are in there. They are not to be chemically and physically restrained unless they are a harm to themselves or someone else. It's much gentler now. They cannot sit in the ER for endless number of hours. They have to be humanely taken care of and placed in hold, but allowed to be free. And that part of the system has changed dramatically in 30 years. And it's much more humane. We have mental health facilities that take care of people that are in crisis. We have police officers that are now trained and they have behavioral health teams. Even in my state that has, in rural Nebraska, they have behavioral health teams that come out to take care of people in mental health crisis that go out with law enforcement. So it's not just police officers taking care of someone in crisis. So I think when I look back in 30, 35 years, the way mental health crisis was taken care of was abysmal. If you go to 30 years before that, we just locked everybody up in an institution. So when I look at these 30-year chunks of time, they have gotten substantially better. So I have hope for the future that we are going to continue to improve upon this, that we're going to have better integration of care. Our EHRs are going to allow providers to talk and integrate more. We will be more preventative. We are going to get that brain-heart connection and talk about more preventative. I get excited when we have ACE studies that talk and acknowledge childhood trauma, and they do it in a medical model. So pediatricians are talking about that, and family physicians are talking about that with parents, and talk about the long-term health consequences of childhood trauma in the medical room, not waiting for that healthcare consequence. So I'm hopeful for the future.
I just want to piggyback real quick because we're talking about crisis care for mental health. Something that I run into are with my clients who have physical health conditions. They're struggling with pain, they're recovering from surgery, but they're also struggling from their mental health, and they go to an inpatient facility, but they're only treating their mental health. They're not acknowledging the physical pain they're in. They're not talking about the pain management. And so that's also something I think we need to look at, is the integration of care in those crisis facilities. We're looking at all of the systems, not just mental health and physical health.
Thank you so much. And to kind of add to that, a different twist, I think that we as providers have to recognize that a lot of what we're seeing is individuals may be maladaptive adaptations to pain and not always pathology. So with that stated, we really have to address the root causes, which is poverty, housing instability, systemic barriers, and lack of access to care.
I think that's
Well
really
said.
important. Very well said, yes. And I know we're at time. So just to quick close, things have changed. I don't want you guys to just hear this and think we're being Debbie Downers. Things have changed. And we're making strides in the mental health field. I think we are trying to start talking to each other as healthcare providers and being less siloed, because integration is so, so important. And we need to remember that all of us, are partners in our patients' care. And so the more empowered that we can make our patients feel, giving them education, psychoeducation, so that they can make their own informed decisions, and involving them in care instead of just telling them what to do, that's really important. And I think that's kind of the takeaway that I want you guys to walk away with, is work with your patients. Talk with them, not at them. See them as a whole person. Thank you.
Thank you so much. Let's give him another round of applause. I think that was, yeah.